if you knew you were about to experience signs of Alzheimer's disease as early as 3 years before these symptoms started, what could you do to prevent Alzheimer's from fully developing? Our guest has the results of a groundbreaking study.
Exercise is definitely helpful. Even just walking is helpful. So there was a recent study showing that walking can help reduce risk. Cognitive engagement. If you have hearing loss, getting hearing aids. There's many different things. Reducing alcohol intake.
Dr. Suzanne Schindler is a clinical neurologist and a neuroscientist at Washington University School of Medicine in St. Louis. Her focus is on improving the diagnosis and the treatment of Alzheimer's disease.
In the past, we just thought of memory problems, cognitive decline as a normal part of getting old. I think that we're increasingly learning that these are that often this is the effect of brain diseases, and we can, in some cases, modify our risks, and now we have some treatments available.
This is Conversations on Healthcare.
Well, Dr. Schindler, welcome to Conversations on Healthcare.
Well, thank you so much for having me join you today.
Oh, that's great. Now, your research is quite interesting, but perhaps creates a bit of anxiety. You and your colleagues have developed a model to estimate when Alzheimer's disease symptoms will begin. Maybe we should start by asking you about the protocol you used in the study. How did you select the research subjects? And just out of curiosity, did they have a genetic predisposition to Alzheimer's?
So those are great questions. So we have known for a long time that this Alzheimer's disease brain pathology actually starts about 10 to 20 years before the onset of symptoms. And we can detect this pathology a variety of different ways. So we have specialized brain scans, we have spinal fluid tests, and more recently we've developed very sensitive blood tests. And so we can detect these brain changes, again, many years before the onset of symptoms. What our study did was try to connect those levels of blood biomarkers, specifically a biomarker called p-tau217, that is now a clinically available test, to use that to predict when people would develop symptoms. Now, these were research participants. These were not people being seen as part of clinical care. And so this is a research project, developmental, and what we found is that there was a pretty strong association between these p-tau217 levels and when people develop symptoms, such that we could predict based on a blood test about when people would develop symptoms. There was still a fair amount of error, so plus or minus 3 or 4 years, so that's still a fair amount. But it does tell us that this is possible, and we know that there's a lot of different things that we can do to make these models better. So this is kind of a version 1, but it's kind of telling us what's coming in the future, which is we think that we'll be better able to predict who is likely to develop symptoms and when. So are they likely to develop symptoms in 10 years or 2 years? That's obviously a big difference in terms of the way you think about your future if you realize you're going to develop symptoms very soon.
Well, this is obviously an area of such intense interest, I think, on part of people in the country, particularly the older population, but also people who've experienced it within their families or within their social networks, and so much fear about it as well. So all knowledge, I think, is incredibly welcome and received that way. But you evaluated patients, as you said, using a blood test that measures the accumulation of amyloid and tau proteins in the brain. I loved your analogy of comparing this to rings on a tree. I think people can relate to that. But you talked about not exactly precise, and I maybe just share a little bit more an example of what would a early ring be versus rings that might appear later on. And you said, or clarify for us, is there a sequencing of the onset, or is it a varied pattern between people?
Well, so those are a lot of great questions. So one thing that we have learned is that once you start to develop higher levels of this p-tau217 or amyloid or tau, that it actually accumulates very consistently over time. So kind of like rings on a tree, as you were saying. And that's helpful. It creates kind of a clock for us. So if a tree has 15 rings, you know that it started to grow about 15 years ago. With this p-tau217, if there's a certain level, we can approximate when it started to increase. And it turns out that the age that you started to have increasing p-tau217 is really strongly associated to when you develop symptoms. We think all of this is helpful and informative in terms of, the error margin. There's lots of things that affect memory and thinking besides Alzheimer's disease. And those include things like medications, other neurological disorders, like whether you've had a stroke or maybe you have Parkinson's disease in addition to Alzheimer's disease. And so all of these things affect the likelihood that you'll develop symptoms. And so as we work to better develop these models and make them more accurate, we'll try to take all of those factors into account. The research cohorts that we used were pretty clean. In other words, they excluded a lot of people that had other neurological conditions, more complicated medical histories. And so that allowed us to see kind of the signal in all the noise. But as these models improve, we'll have to take all of those different factors into account that, of course, when we apply this more generally, become really, really important.
Mm-hmm.
Now, you're right that older individuals had a shorter time when the elevated tau levels appeared to start of symptoms compared with younger participants. Tell us what this says about younger people's brains and their resiliency.
Yes, so this was a really dramatic result of the study that we didn't necessarily expect. Normally when you think about a test, a positive result means similar things, regardless of your age, that you have the condition or not. But when it comes to predicting risk for symptoms, we found that if you were 60 when you became positive on this p-tau217 test, that it took about 20 years before you developed symptoms. But if you were older, about 80, it only took about 11 years. And this actually makes a lot of sense because we know that older people have more neurological conditions and medical issues that reduce their brain resilience and make it more likely that if they have a brain disease, that the symptoms become manifest. So it also speaks to the fact, though, that we need to really do everything we can for our brain health. And whether that's diet or exercise or making sure that we're managing our diabetes or hypertension to make sure that our brains stay healthy so they're more resilient when we do develop these brain diseses.
What are some of the common symptoms that arise? Is there any standard ones or does it vary? There certainly is variability, but kind of the classic features that we look for with early Alzheimer's disease are pretty specific. So we see that people start repeating questions or statements. So they'll ask you a question, then 15 minutes later, half an hour later, ask you the same question, do that multiple times. They'll misplace items much more often than in the past. They'll forget appointments. They will have a conversation with you and then later forget major details of it, or they'll have a personal event, go somewhere, and then later not remember the details. So those are the sorts of things. Of course, we all have memory lapses from time to time, so we have to be aware of that. But when people change, when there's a consistent change over months, 6 months or more, and it's getting worse, that's when we really start to wonder whether the patient maybe has early Alzheimer's disease. And that's when we need to do an evaluation and biomarker testing. And increasingly, people are using blood tests for that first test to see if someone has Alzheimer's disease pathology.
Well, this, maybe I've been asleep at the wheel, haven't been aware that these tests have arrived in common outpatient primary care practices, and the clarity with which you're speaking of it and what would happen after, for a long time was don't test for something that you have no treatment for has always kind of been a standard. Yeah. Now we're saying test for something that you may be able to at least mitigate or reduce the impact. What is, and this is an opinion maybe more than science, what's your sense about how widely how significant the uptake is among the, say, over 60 population in primary care across the country, in offices, and do the clinicians who are ordering the test know what to do in terms of resources and response? Could you just, maybe share your opinions on that from you and your colleagues?
Yeah, again, really great questions. So one thing about these blood tests is they've developed very quickly. So we didn't have blood tests for Alzheimer's disease, 6 years ago, but they developed very quickly. And now we actually have highly accurate tests, and 2 of them have even been cleared by the FDA. There's more tests that are being evaluated by the FDA that'll probably be cleared soon. And they're increasingly available, and they're available from major diagnostics companies, including from C2N Diagnostics, LabCorp, Quest, Mayo Clinic Labs. So basically, any doctor can order these tests right now. The major gap is that most doctors don't know which test to order, how to interpret them, all of those kinds of issues. So at this point, I'd say that the biggest gap is actually clinician education, and also that many of these tests are not reimbursed, so you may have to pay for them out of pocket. But they most definitely can be ordered. And I do think they will transform care, but sometimes it takes time for people to incorporate into these kind of new tools into their thinking. And of course, we now do have 2 FDA-approved treatments for Alzheimer's disease, lecanemab and donanemab, that we know are that are safest and most effective when we give them early. They are not helpful later. So that really creates a sense of urgency that we should try to diagnose people early. Mm-hmm. And we're becoming increasingly aware that there are different lifestyle modifications that may also be helpful. So yeah, in the past, we just thought of memory problems, cognitive decline as a normal part of getting old. I think that we're increasingly learning that these are that often this is the effect of brain diseases, and we can, in some cases, modify our risks, and now we have some treatments available.
Margaret, I always get confused between dementia and Alzheimer's. And Alzheimer's is always dementia, but dementia is not always Alzheimer, right? Is there any confusion in terms of when you're diagnosing people between just dementia and Alzheimer's?
So that is the number one question that I'm asked by my patients. Mm-hmm. And it is a major confusion for many people. So dementia is just a general umbrella term that means that someone's had a decline in their memory and thinking that affects their function to some degree. And there's many, many causes of dementia, and some of them are reversible. So, for example, people that are taking 6 different sedating medications and have sleep apnea, we can sometimes fix that and they can improve. But in older individuals, those older than age 65, the most common cause is Alzheimer's disease. And Alzheimer's is a specific brain disease, and it's characterized by these amyloid plaques and tau tangles in the brain. And that's what these blood tests reflect. They reflect that the amyloid plaques and tau tangles in the brain. And we do these blood tests in patients who have cognitive impairment to try to understand whether their symptoms are due to Alzheimer's disease or something else. If the test is positive, it tells us, yes, the symptoms may be related to Alzheimer's disease. If the test is negative, that's also helpful, right? It tells us it's not Alzheimer's, you need to look somewhere else. Mm-hmm. So I think these tests will be more and more helpful, and primary care doctors are increasingly ordering them, but there remains a lot of education to be done about how to use them.
You were saying that it's not covered by insurance. Our population we're concerned about is certainly Medicaid. Are you seeing any places where it's being covered there.
Yeah, so right now there's a lot of inconsistency. So I'm hearing that sometimes the tests are paid for and sometimes they're not. And so I always warn my patients that the test may or may not be covered. There's actually billing codes so they can be covered, but there's just a lot of fragmentation of our healthcare system with different insurance plans, and sometimes they'll approve it and sometimes they won't. I expect that as these tests are used more widely, that they will get more consistent reimbursement. But right now, it's just unclear whether they will be paid for or not. And sometimes the tests are a couple $100, and sometimes the tests are $1,450. So it depends on the test. There are patient assistance programs for some of these tests to get them covered. So even the expensive tests may only cost $50, but it takes some research to figure this out.
Yeah.
Well, I would presume, I could be wrong, that there will be huge demand for the test. Some people will avoid it, don't want to know the answer. Of course, we always run into that in healthcare. But I would imagine they will be highly sought. If CMS is not covering it under Medicare now, I would imagine this would be a high demand. But one of the paradoxes is sometimes whether it's with smoking or anything else, there are certain triggers that make people say, this is the day I stop the drinking or the smoking, or I start exercising, I change my diet, I get my lipids under control, all of those things. Tell me, what are you seeing and your colleagues who are engaged in this research in terms of this being a precipitating factor for people really both needing to and actually making lifestyle changes? Is that part of the counseling that goes with the results of the tests?
Yeah, so it's complicated. So right now we only perform these tests in people who already have cognitive impairment. So they're
self-diagnosed or diagnosed by somebody else. If the patient shows up reporting it, self-reporting, would that be enough to get a test?
So right now, no. So if a patient comes in and they're concerned about their memory and thinking, we would do testing. And if they have impairment at that point, then we could consider doing a test.
I see.
But if someone's just concerned, we do not at this point recommend testing because of it's a variety of issues. But one is, for example, you could become ineligible for long-term care insurance or be subject to discrimination. There's just
right. But it seems counterproductive to your research, which shows the earlier you detect it, the greater your chances of responding to the medication. So some conundrums, which are part of part of health and healthcare, that is definitely one of the conundrums, I would imagine.
Indeed. But yes, I think there are people who are very proactive, who really want to know and would change some factors in their life if they knew they were positive. That said, they should probably change those factors even if they're negative. Right? You can make that argument too. We all know that we should eat better, sleep more, and exercise more, and yet sometimes we don't do it. But you're right. Sometimes some kind of individualized information can spark change. So it is something to think about.
I think about the casual viewer of healthcare issues. They come across this in the newspaper about some new research that can ward off Alzheimer's disease. What's your perspective on what someone can be doing now? And we talked a little bit about this in terms of exercise. Is there any definitive, or just have a healthier lifestyle? Should I be walking? Should I be, anything that actually makes a difference?
Yeah, so there actually are guidelines. So the Lancet Commission has looked very closely at factors that are associated with risk for dementia. And a lot of them are things that you might expect. And exercise is definitely helpful. Even just walking is helpful. So there was a recent study showing that walking can help reduce risk. Cognitive engagement, if you have hearing loss, getting hearing aids. There's many different things, reducing alcohol intake. Again, a lot of these are really healthy living kinds of things and are somewhat common sense. But the Alzheimer's Association actually has information on those specific things that you can do to decrease your risk over time. Now, once people develop symptoms, it's actually more challenging. And unfortunately, as a dementia specialist, I regularly see people who did everything right. They had a wonderful lifestyle. They did exactly what they were supposed to do, and they still got Alzheimer's disease. Some of them do have genetic risk factors that make it more likely that they'll develop symptoms, and some of them just are unlucky. So you can do all of these things to reduce your risk, but unfortunately, some people still will develop Alzheimer's disease dementia.
Sure. So many questions. We could keep you here all day, but just going to continue on a little bit more. I would imagine that you're part of a team of people, and that there are multi-center teams all over the country and the world, probably, that are looking at this. And I'm curious, we've been part of the National All of Us project with the NIH for many years for our patient populations across the state. And I wonder what the understanding is to date in terms of regions of the world, the demographic factors between and among people. Do we have any kind of emerging patterns around that? Other diseases earlier in life that may have contributed? To share again, you are doing such great research, but I know you also are linked in probably to a large community of researchers in this area.
Yes, absolutely. So dementia has a huge impact around the world. Not just in the United States, but around the world, even in developing countries. So actually some of the biggest rates of increase in dementia are in places like India. Our population is aging, and all of these neurodegenerative disorders are associated with older age. So we expect this is going to get worse. There is variability in different populations. Some of this is likely related to lifestyle factors. So, for example, some populations have much higher risk of cardiovascular disease and stroke. So in those populations, a lot of the memory and thinking problems are driven by that, in addition to Alzheimer's disease. But in other populations, they don't have those risk factors, and they have high rates of Alzheimer's disease. So it really varies quite a bit across populations, but what's consistent is Alzheimer's disease is really in all populations. It may have a variable effect on whether or not people develop symptoms. There may be variance in the genetic factors that contribute, but it's a human problem. It affects really all of humanity, and the impact will certainly increase as our population ages.
The Food and Drug Administration has recently approved some new therapies to treat Alzheimer's. How do they work, and are you seeing results? And is the main course of treatment monoclonal antibodies? Is that the preferred?
Yes. So there are two treatments that receive traditional FDA approval. One is called lecanemab, one is called donanemab. They are both antibodies that bind to the amyloid plaques in the brain, and they actually activate the immune system to clear the plaques out of the brain. The issue is that by the time people have symptoms, that they already have a lot of amyloid, and they've developed other damage from the amyloid and associated effects. So we do see significant effects of the amyloid clearance. So it slows cognitive decline by about 30%, and it looks in open label extension studies like the effects increase over time, which is very promising. But people still unfortunately decline. So we need more treatments. And unfortunately, we have a rich pipeline of treatments. We expect that we'll get more treatments in the hopefully not too distant future, and we may add those on to the amyloid clearing treatments. The other thing is there are exciting trials underway right now where we're providing these amyloid clearing treatments before people develop symptoms. So before they've developed a lot of the secondary effects of amyloid. And those are going to read out in the next couple of years. And if those are positive, if they show clearing amyloid before symptoms develops actually slows or prevents the onset of symptoms, I mean, that could really be revolutionary. So that's very exciting. And if we get to that point where we have treatments that can prevent development of symptoms in people who have positive blood tests, then that's when we're going to have to start screening lots of cognitively unimpaired individuals with blood tests. And that may not be that far away, actually. So
I'm pretty willing to bet that if we had the ability for our audience to be dialing in right now, they would be saying, what the heck? Why aren't we screening people now? I think everything you've said in the last few minutes, and while optimistic about the future tests, it does sound like knowing today gives you greater potential to perhaps enroll in trials, to monitor yourself, to be screened more thoroughly. You know, we all have a general sense of how our memory and mental status is, but that's different than having somebody do a cognitive assessment. So what are you hearing from I'm sure the Alzheimer's associations and so forth are following your research avidly. What are you hearing from the consumer community about the need to have access more widely available to testing without symptoms, just on the basis of age?
Yeah, so I think there's tremendous interest, but right now I would say in the medical community there's a broad consensus not to do the testing in the cognitively unimpaired individuals because we don't have a specific treatment at this point. As we talked about, it may affect people's level of motivation to institute lifestyle changes, but they should still do it anyway. And we are worried about some of these legal risks. But, these are things that we're actively working on to try to deal with these issues. And I think that the bottom line is things are changing very fast. And if we get treatments that can really prevent onset of symptoms, again, that will really change the equation
landscape
very quickly. And just one other note that these blood tests have really advanced very quickly, and we expect they'll continue to advance, and they become available and FDA cleared just in the last year. So again, we're really at this tipping point where lots of things are changing, and I expect it'll be a major topic of conversation over the next few years.
Let me just slip in one quick question. Tell us a little bit about you and what led you to do this very important research.
Well, I've been interested in Alzheimer's disease for a very long time, since high school, actually, because I knew a friend had early onset Alzheimer's disease, and it was really devastating. But then, of course, as I got into the field, I've met thousands of people affected by Alzheimer's, and it's really a devastating disease. So it's made me very motivated to try to advance the field for patients and caregivers. And in terms of this specific question, so I've been involved in clinical trials where we screened older individuals with biomarker tests and found some that were positive to enroll them in these clinical trials. And when they found out they were positive, the first question they asked us, well, so how long do I have before I develop symptoms?
Right.
Am I going to develop symptoms in 1 year, 5 years, 10 years, never? and I realized that there was really no way to know, kind of given current mathematical models. So really for over 5 years, I've been working to try to answer these questions. And the study that we published, I think, provides some insights in how to do this. I still think of it as kind of a version 1, but given how fast our technology is advancing in these assays, and also our analytical methods with artificial intelligence, I think that pretty quickly we'll be able to refine these models so they're even more useful.
Well, that is an optimistic note to close on. And Suzanne, we want to thank you for joining us for this very insightful program. And thank you to our audience for being here. Just a reminder to subscribe to our videos on YouTube, find us on Facebook and X, and please share your thoughts and your comments about this program. Take care and be well. This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.